So my name's Shawn+West. I'm actually one of the pediatric cardiologists at Children's, so I'm not a lung doctor. But as a pediatric cardiologist, I take care of the kids with pulmonary hypertension. And with that, I see kids with interstitial lung disease and other lung problems who have pulmonary hypertension, who have other problems with their heart due to their lung disease. And with that, I was asked to give a talk on pulmonary hypertension. I first kind of started to put this talk together, and I put it together just as effects of the heart due to lung disease in kids that have chronic lung problems. And then I thought that was kind of too broad of a talk, and that probably should be 2 or maybe even 3 talks. So then I kind of narrowed it down to just pulmonary hypertension, and the title kind of pulmonary hypertension and lung disease. But as you'll see as we get through it, it's really kind of a general pulmonary hypertension talk, because pulmonary hypertension in and of itself with lung disease is specific in lung disease, but we still sort of treat it the same, whether it's due to lung disease or whether it's just pulmonary hypertension without any other cause, or whether it's due to something else. The end outcomes may be different, and how the drugs we use may be a little bit different. But what it is sort of basically the same. So kind of my objectives for this talk would be to kind of define what pulmonary hypertension is, sort of to talk about it. Because a lot of people think they kind of know what it is, and it sort of sounds like it should be pretty obvious. But then when you start to talk about it, we talk to families, even start talking to some of my colleagues, whether they're cardiologists, whether they're pulmonologists, lung doctors, whether they're other subspecialists, a lot of my colleagues don't really understand what pulmonary hypertension is. And sometimes we have different ideas of what pulmonary hypertension is. Talk about what some of the causes are, both lung causes and some general causes of pulmonary hypertension. Talk about what the symptoms are, both early in childhood, later on in childhood. Then how, as a cardiologist, how I make the diagnosis of pulmonary hypertension. And then talk about the possible treatments of pulmonary hypertension. So I don't expect anybody to kind of read this or really the next slide either, but when I start talking to families about how I make a diagnosis of pulmonary hypertension, what the outcomes of their pulmonary hypertension for their child is going to be, both short-term and long-term, and what the possible treatments are, one thing I go by is kind of what the guidelines are, for expert guidelines are for me to treat pulmonary hypertension. And there's kind of 2 sets of guidelines as I'll show. One set is the U.S. guidelines that came out from the American College of Cardiology, and it's an expert consensus document. It is based on a bulk of it is based on evidence. It's based on some clinical trials that we have done and the pulmonologists have done. It's not a lot of randomized trials. So if one of us got sick and we went to an adult physician, whether it's for pulmonary hypertension, or especially if it's for heart disease, if it's for diabetes, and we ask our doctors, how they're basing their decision of what they were going to treat us with, why they were going to treat us for heart disease, what they were going to put us on for diabetes, and what they were basing that on, they would probably say the same thing. They were basing it on an expert document, but their expert documents are based on large clinical trials. They're based on clinical trials of thousands of people, sometimes tens of thousands of patients that are done all across the country at some of the large centers, and they get a lot of evidence. For pediatric patients, we can't do that just because we don't have thousands of kids with the same disease that have the same problems that we can enroll in trials and put on different medications all at the same time, or put some sets on medications and some not, to see if they'll get better on certain medications and not. Because in some cases, with some diseases, we may have a few hundred patients at one center, a few hundred patients at another center, and when those kids are pretty sick, so it's not fair to not treat some of those kids. So our trials are often looking back at our experience and saying whether those kids got better or not, or pulling data from us, from some centers on the West Coast, from centers in Boston or Chicago, and putting some kids on one therapy versus other kids on a second therapy and seeing which therapy is better. And then experts get together, look at all that data, and then they write up evidence like this. I know Dr. Curlin is working on coming out with an expert opinion on interstitial lung disease. And sort of these consensus documents are really that. They're expert opinions. They're people that are considered the experts in their field. They get together at large meetings, and they write the consensus documents. And some of these take quite a long time to come out. They're usually small updates that come out every 3 to 4 years, but the large documents like these come out about once every 10 years. So this is the U.S. Or American document that most of my colleagues use. It last came out in 2009. And there's also a European guideline that also came out at about the same time. And it has basically the same information. There are some things in it that are worded a little differently. And it also talks about some medications that aren't available in the U.S., both for good and for both for good reasons and for some things that are coming down the pipeline in the U.S. that aren't quite available yet. I mean, that are in the pipeline in Europe, in some European countries that aren't available yet. They're still in clinical trials in the U.S. So when we talk about pulmonary hypertension, I think it's important to kind of define pulmonary hypertension, whether it's for families or whether I'm talking to some of my colleagues, just so I know that I know what I'm talking about, and so that other people I'm talking to know that I know what other people are talking about, so we all get kind of on the same page. When I talk about pulmonary hypertension, I'm simply talking about the blood pressure in the arteries in the lungs and the blood pressure in the right side of the heart. So it's similar to the blood pressure in the body. When we talk about just hypertension, which is high blood pressure. So that's the blood pressure that we take when we go to the doctor. So blood pressure in the arm, blood pressure in the leg, and that's systemic hypertension. So pulmonary hypertension is the blood pressure in the artery out from the heart to the lungs, or so blood pressure in the right side of the heart, and that then becomes the blood pressure in the veins in the body. Blood typically that comes from the body goes from the veins in the body back to the right side of the heart, and then it'll go from the right side of the heart out to the arteries in the lungs. So the heart and the lungs are then connected, and blood from the lungs then goes back to the left side of the heart, and from the left side of the heart then goes back to the left side of the heart then goes out to the body. Typically, the blood pressure in the lung arteries is about a quarter or a fifth of the blood pressure in the body. So if our blood pressure is 120, the blood pressure in the artery in the lung should be about 20. But with pulmonary hypertension, the blood pressure in the arteries in the lungs is typically the same. So for someone with pulmonary hypertension, the pressure in the arteries in the lungs will often be 100 or 120, the same as the blood pressure in the body, or sometimes even higher than the blood pressure in the body. There's multiple causes of pulmonary hypertension, as I'll show in the next few slides. It eventually leads to heart failure. And as a cardiologist, I use heart failure. As a pediatric cardiologist, I'll use heart failure differently than often my adult colleagues will. And I'll talk about heart failure with pulmonary hypertension. I'm really talking about heart failure of the right side of the heart, which is different than the left side of the heart. And as an adult, if I go to an adult cardiologist, or if any adult goes to an adult cardiologist, typically an adult cardiologist will talk about heart failure, meaning the heart failure of the left side of the heart. But with pulmonary hypertension, you get heart failure of the right side of the heart. And the long-term symptoms of pulmonary hypertension really have to do with when heart failure develops and how well the right side of the heart handles the pulmonary hypertension. And one thing I always kind of stress to patients as they get old enough, and to families when they're diagnosed, and to families, especially early on, is that pulmonary hypertension is a bad thing. Most patients with pulmonary hypertension won't survive without therapy. And even with therapy, patients with pulmonary hypertension are going to have a shortened lifespan. How short their lifespan is, to some degree, depends on the cause. Then depends on what kind of therapy that they're willing to take, and that they're willing to and how well they do with their therapy. So this is a busy slide. One thing I wanted to show is on the far left is an artery out to the lungs, and it's a normal artery. There's nice and smooth walled. The muscles are normal in size, and blood is able to get through that artery normally. On the far right is our lung arteries that have lungs of someone with pulmonary hypertension. The arteries are very thick. The muscle of those arteries are thick, and there's hypertrophy of the arteries, meaning that they've become thicker over time, and for some reason the pulmonary arteries just become abnormal. It's not just that the muscle becomes thick, but the lining is abnormal, and it has to do with a lot of different effects on the lung arteries, some of which we understand, some of which we don't quite understand. And the effects that we do understand, where we do have some medicines that specifically treat those effects. But as I'll talk later on, the medicines we have to some degree regulate the effects of pulmonary hypertension, but nothing reverses it completely. Our kind of goal with therapy is just to stabilize pulmonary hypertension and try to make kids feel better. This is also a busy slide. This is taken directly from the consensus statement, and this shows there's a lot of different causes of pulmonary hypertension. Starting from the top, there's patients that have idiopathic pulmonary hypertension, which is primary pulmonary hypertension, and this is probably the bulk of kids that I see in childhood, whether there's early childhood or especially in teenage years. There are patients that show up with pulmonary hypertension, and we look for other causes, particularly lung causes. We often find no other causes, and then we end up just treating them for pulmonary hypertension. There's also patients that have congenital heart disease, and there's particularly patients that I see or my general cardiology partners see. And along with that, they then develop pulmonary hypertension. You can have inflammatory diseases that can cause pulmonary hypertension, like lupus, scleroderma, rheumatoid arthritis, and then you can have problems with the liver. There's problems with blood clotting that can cause pulmonary hypertension. But really, but in the middle of the slide, we talk about lung disease as a cause for pulmonary hypertension, and that's a significant portion of kids with pulmonary hypertension. And then the guidelines then break out the percentage of the subtypes of kids with pulmonary hypertension for lung disease. And to break them out more, really we talk about kids that have lung disease since birth, so kids that were born premature and have BPD or bronchopulmonary dysplasia that becomes chronic lung disease, so kids whose lungs are born at 3 or 4 months premature. Their lungs are developed early and don't develop and are still developing at the time of birth. They go on to have pulmonary hypertension because of lung disease. Those kids have a good chance of outgrowing their pulmonary hypertension because lungs continue, the alveolar portions of the lungs, the air sacs in the lungs continue to develop until kids are 6, 7, or 8. As the lungs continue to develop, the pulmonary hypertension has a good chance of getting better. Some kids have interstitial lung disease, as we're here to talk about. You have kids that have sleep disorder breathing or alveolar hyperventilation disorders, where either for lung reasons or because of brain reasons, they just don't breathe properly. Kids at real high altitudes, so kids that live in mountainous areas, not just in Denver, but kids that I've seen from South America, or kids that are described living in the Himalayas can have pulmonary hypertension because they breathe because they're from high altitudes and they don't have enough oxygen dissolved in their blood. Kids that snore or they have upper airway obstruction. Children that are born with a congenital diaphragmatic hernia, which is where the muscle lining between the lungs and the abdomen is not formed properly when babies are born. So the stomach or some of the intestines are up in the chest cavity when babies are still developing, and this causes the lungs not to develop properly before they're born, leading to pulmonary hypoplasia, which is where the lungs aren't developed properly. This can cause the lung arteries not to develop properly. Cystic fibrosis, a genetic problem with the lungs, and sleep apnea, so a type of snoring, and specifically interstitial lung disease. So what symptoms can we have with pulmonary hypertension? So I think the symptoms we have with pulmonary hypertension are a little different depending on what age groups kids develop pulmonary hypertension. Certainly kids that have lung disease, if they have lung disease from birth, typically will develop earlier. They'll have lung disease as infants. Those kids may have failure to thrive. They may present with heart failure symptoms at an early age. Kids with congenital heart disease often may have pulmonary hypertension at an early age, but they typically don't have failure to thrive symptoms. they'll have symptoms of their heart disease. If you have idiopathic or primary pulmonary hypertension, those kids sort of present at two times. They may present early in childhood, but they often won't present until later. They may be normal during childhood and not have pulmonary hypertension, and they may present with pulmonary hypertension later on in adolescence or teenage years, or sometimes even in adulthood. Inflammatory diseases such as scleroderma or lupus, those children may present with pulmonary hypertension, but their presentation will be based on their inflammatory diseases. And depending on their inflammatory diseases, they may have a peak at early in childhood or late in childhood. If you present later on in childhood, you're more likely to have shortness of breath, which we call dyspnea. You may have exercise intolerance. You may have a teenager that's been able to keep up with his friends playing football or basketball that all of a sudden can't. You may have a child that passes out all of a sudden, particularly passes out with exercise or syncope. You may have a teenager that presents with chest pain. So if we see a child that passes out with exercise or that presents with syncope, particularly a teenager, those are two of the things that I always look for and try to, those two things are something that I always worry about. And then I always evaluate them for pulmonary hypertension. And we probably see, in our general cardiology clinic, we probably see 3 or 4 kids a day, every day for passing out and chest pain. I would say 95% of the time, if I see somebody for passing out and chest pain, they're fine. They usually have nothing wrong with their heart. But every few months, we do see somebody that has a cardiac cause, a heart problem that make them pass out or that made them have chest pain. And every so often, we will see somebody that presents with heart failure symptoms. Our last patient that presented with pulmonary hypertension presented just with right heart failure and with heart failure symptoms with lower extremity swelling, swelling of their neck, swelling of their face, and exercise intolerance, just generally not feeling well, and had been going on for 2 or 3 months, but had not passed out yet. And then we sort of take those symptoms, and then with that, we sort of look at how well the patient's doing. But a lot of time, and with that, we also sort of take how the patient's doing, and we sort of look at how bad the pulmonary hypertension is. Just with how bad the pulmonary hypertension is doesn't necessarily mean the patient's going to be feeling well or feeling poorly. A patient can have severe pulmonary hypertension and do well, have very few symptoms, and kind of go about their normal activities for several months or several years. At the same time, a patient can have moderate pulmonary hypertension, but if it comes on very rapidly, or if their right heart doesn't handle it, they may become very symptomatic in a short time span. So kind of the symptoms that develop with pulmonary hypertension are based on how well the right heart handles their symptoms. And we sort of put all that together by thinking about how functional the patient is. And we use a functional score to help us evaluate the patient over time. And we use a functional score called the World Health Organization score. It's based on the New York Health Association heart failure score. And it's based into four scores. So score 1 has no limitations of physical activity. So this would be a patient that's basically asymptomatic. They may have moderate, severe pulmonary hypertension, but they're either handling their pulmonary hypertension well or they're well controlled on medications. Then a class 2 would be slight limitations of physical activity, but comfortable at rest. So somebody that's able to go about their day-to-day activity and not have any symptoms at home or with light activity. A class 3 would be marked limitations of physical activity, but comfortable at rest. So this would be a patient that I would be more concerned about and start to think about escalating therapy and talk about the next stage of therapy. And then a class 4 would be inability to carry out physical activity, symptoms of right heart failure. And again, with right heart, I start to worry about right heart failure because to me, that's a marker of how well a patient is going to handle pulmonary hypertension and how well they're going to do long term. And they also have symptoms at rest. So they're not able to carry out any activity, and they have problems just sitting around the house. I think it's the first time I see a patient, one thing I always ask is for family history. It's not as important in patients just with lung disease, But often when we first see a patient, I don't know if it is just, if I know a patient has lung disease and it's somebody I've seen from Dr. Curlin or Dr. Spar, then I kind of sort of target my therapy and I target my thinking with the patient. But often I'm seeing a patient first because I'm seeing a patient that's gotten picked up with pulmonary hypertension and we don't know what the cause of it is. I don't know if they have lung disease. I don't know if they have a problem with their heart. I don't know if they have an inflammatory disease, or I don't know if it's idiopathic primary pulmonary hypertension. If you take all comers, if you take all patients with just pulmonary hypertension, including lung disease, including idiopathic pulmonary hypertension, and including heart disease, probably 6 to 10%, 6 to 12% of patients will have a positive family history. If you include all the patients with congenital heart disease with pulmonary hypertension, the genetic cause is probably even higher. But with idiopathic pulmonary hypertension, there is a genetic cause we've identified that's autosomal dominant. So that means that if you have the gene, you have a 50% pulmonary hypertension, you have a 50% chance of giving that gene to your children. That gene is called a bone morphogenic protein receptor, or BMPR. And that gene is probably in 6% of patients with primary pulmonary hypertension. So that's the gene that we test for in patients with primary pulmonary hypertension, particularly if there's a family history of other family members with pulmonary hypertension or other family members with heart disease or that died at a young age and it was unclear why they died. There are also patients with connective tissue disease like lupus, scleroderma. That can be a familial component, and that can run in families with at least patients can have scleroderma that runs in families, and then one patient in the family can have pulmonary hypertension of those. And then there are some familial types of infiltrative lung disease and other types of lung disease, and then that can manifest as pulmonary hypertension in some family members. So when we talk about symptoms of pulmonary hypertension, talk about kind of how we grade pulmonary hypertension and kind of how we get to a diagnosis of it. That kind of leads us, to testing. And I think testing kind of really helps me with a diagnosis for families, because often we have an idea that somebody has pulmonary hypertension, but then there's a workup. When I see a new patient with pulmonary hypertension or a new referral for pulmonary hypertension, sitting down, talking to the families and educating them about pulmonary hypertension and kind of going through an exam, even before getting to cardiac tests, is often a 2 or 3 hour visit. And then often the additional test, just on the clinic day, probably takes another hour, hour and a half. And then the additional testing we take probably takes another day. So these are often 2 or 3 day visits, at least for the first time. Because in addition to seeing me, if we think they have lung disease, or if we don't know what the problem is, they're seeing Dr. Curlin or Dr. Spar, or one of their partners. So kind of the basic cardiac test that a patient will get will be an electrocardiogram or ECG. They'll always get an echocardiogram. They'll sometimes get a stress test, especially an older patient. A stress test is like a stress test for an adult. It's an exercise stress test where they're run on a treadmill. Then with that, we'll see if they have any rhythm changes of their heart, or see if they have mild pulmonary hypertension. We'll also use an exercise stress test with an echocardiogram, to use an echocardiogram before the stress test, and echocardiogram after, to see if there's any changes with the pulmonary hypertension or changes on echocardiogram after the stress test. We don't often use this as a diagnosis on the first visit with pulmonary hypertension, but we will use this to follow older children with pulmonary hypertension, to follow our therapy, and to follow patients with mild pulmonary hypertension to see if they improve. We use a test called a 6-minute walk test. This is really more of a pulmonary test, and it's something the pulmonary lab does for us. And it is basically as it sounds. It's a test where patients walk for 6 minutes, and we measure how far they walk in meters or in feet. We check their oxygen levels and their blood pressure and heart rate at the beginning, and we check it out at the end to see if their oxygen levels drop, if their blood pressure changes, if their heart rate changes. And there's a normal number for age for children and for adults about how far a child at age 5 is supposed to walk, at age 6 and so forth up to adulthood. A good ballpark figure for older children is 600 meters. And then 300 meters is probably a cutoff that's pretty poor. Usually once kids are 7 or 8 or 9, we can start to get kids to do an effective 6-minute walk test. And the same for a stress test. We don't want to get small kids to run the treadmill because we feel it's it's dangerous. Other lung tests we would do for a patient would be pulmonary function tests, just like the lung doctors do. And we ask the lung doctors the pulmonologists to do that for us. So these are kind of the basic tests that I would do in the office. Other advanced tests we would do would be a cardiac catheterization. And as I'll show in a minute, we consider a cardiac catheterization to really kind of be a gold standard that helps us make the diagnosis. We also would use a cardiac catheterization anytime we think therapy isn't working. If we think we really need to escalate therapy, or if we think that the patient's changing. But we do have some patients that have a cardiac catheterization at the time of diagnosis, and they may not have another cardiac catheterization for 8 or 10 years. For other reasons, or for other patients, we may have to do a cardiac catheterization every year to every year and a half, depending on what their therapy is. We'll sometimes do a CT of the heart, or a CT, particularly of the lungs, both to look at the lung fields and of the arteries that go from the heart out to the lungs. And we'll sometimes, particularly for heart patients, do an MRI of the heart. A basic test the lung doctors do is a chest X-ray. This is a sample chest X-ray of a patient with pulmonary hypertension, and it basically shows that the heart is enlarged, as I would expect in someone with pulmonary hypertension. There's increased lung markings of the main pulmonary artery up close to the heart here, but further out the lung fields look black. It's easier to see with the lights out. Normally the lung fields are very kind of white all the way out. With pulmonary hypertension, the lung fields look black the further out, all the way out, and that's because blood has trouble getting out just further out into the lungs when the blood pressure is high. I use an electrocardiogram to look at voltages in the heart. With pulmonary hypertension, the voltages on the right side of the heart are high or strong here, and the other voltages are normal. Typically, those voltages should all be the same. And then with pulmonary hypertension, I primarily make a diagnosis with echocardiogram. That's often the first test a patient will have that suggests pulmonary hypertension. Echocardiogram is a useful tool because it's basically ultrasound. So it's non-invasive. It's a relatively quick test. An echocardiogram in our clinic takes 30 or 45 minutes. By the time we review it, and look at it, it can take up to an hour to hour and a half. But the scanning time is relatively short. And we do it for kind of 4 reasons. We do it to evaluate the pressure in the right side of the heart, and there are techniques with echocardiogram that we can use to estimate the pressure in the right side of the heart and the pulmonary arteries. We can't directly measure the pressure in the right side of the heart because it is non-invasive, because the way the ultrasound is non-invasive. The only way to directly measure the pressure in the right side of the heart is with cardiac catheterization, and I'll show that in a minute. We use it to look for congenital heart disease, so for a secondary cause of pulmonary hypertension other than lung disease. We use it to look for intracardiac shunts, which are holes in the heart. So what I would call an ASD or a VSD, a hole between the top chambers of the heart or the bottom chambers of the heart. We use it to look for function of the heart, so how well the heart's squeezing, particularly the squeeze of the right side of the heart and how well it's handling pulmonary hypertension. And that's typically a test that our patients with pulmonary hypertension will have every time that we see them in clinic. And often they'll have it when they come to the emergency room for some reason, or they're in the hospital for some reason. These are just going to be echocardiogram videos. The echocardiogram on the left is of a patient with with the normal heart. The echocardiogram on the right is an echocardiogram video for someone with severe pulmonary hypertension, and it shows that the bottom chambers are the left ventricle, the top chambers of each video are the right ventricle. The video on the right shows the right ventricle that is severely dilated and enlarged due to pulmonary hypertension. It's much bigger than the ventricle on the video on the left, and it also has decreased function or decreased squeeze. Similarly, the video on the left is from a normal heart. The video on the right is an echocardiogram video from a patient with severe pulmonary hypertension. This is an apical view where in each video, this is the right side of the heart, this is the left side of the heart. In the normal patient, the chambers are about the same size. In the patient on the right with pulmonary hypertension, the chambers of the right heart are severely dilated. And the right ventricle of the patient with pulmonary hypertension has decreased function or decreased squeeze. There's valves in the heart that connect the chambers. The valve on the right side of the heart is called the tricuspid valve. We use how much leakage on the tricuspid valve to help us estimate pressure of the right ventricle. Often in patients with pulmonary hypertension, the tricuspid valve leaks more than it should. And then the picture on the right, the patient with pulmonary hypertension, the tricuspid valve has moderate to severe amount of leakage, which is abnormal. This is in comparison to the patient on the left that only has a trace amount of leakage of the tricuspid valve. So again, to remind us, the definition of pulmonary hypertension is elevated blood pressure in the arteries from the heart out to the lungs. And we can estimate that with echocardiogram, but we use echocardiogram to only estimate the pressure really in the right side of the heart and the right ventricle. There are some methods we use to estimate the pressure in the lung arteries, but they're sometimes inaccurate. We have to have leakage of the valves, as I showed in the video before. If there's no leakage of the valves, it becomes more difficult with echocardiogram. I can often say that there's evidence of pulmonary hypertension, but I can't say what the pressure measurement would actually be. To do that, to make a diagnosis, we usually have to resort to cardiac catheterization. Cardiac catheterization is considered the gold standard from how we make the diagnosis. The recommendations are for children to have a cardiac catheterization at the time of a diagnosis of pulmonary hypertension. You don't think you need to know the numbers, but basically the cardiac catheterization will show that the pressure in the right side of the heart and the lung arteries is high. It should show the pressure in the left side of the heart to be normal. It should show that the connection of the lungs back to the left side of the heart should be normal as well. And then we'll do angiography of the lungs and the pulmonary arteries as well to look at the arteries that go out to the lungs, and then we'll look at how those how the lung returns blood back to the left side of the heart. And this is just a mock-up of what a cardiac catheterization looks like. This shows a catheter coming from one of the veins in the body to the top chamber in the right heart. That catheter then goes through the right heart out to the lung arteries, and it's called a pulmonary artery catheter. With that catheter, we can measure pressure in the right heart. We can measure pressure in the artery out to the lungs, and then by blowing up a balloon in the catheter, we can measure the pressure past the balloon. And with that balloon up, we can measure pressure in the left side of the heart. This is an angiogram taken from a patient during a cardiac catheterization. The catheter is in the right pumping chamber in the right ventricle in the right heart. As a dye will be injected from the catheter, it will fill the right ventricle and will be pumped out to the lung arteries. And what you see is the right ventricle is dilated, it's bigger than it should be. The pulmonary artery, as it here, as it goes out, is dilated, is bigger than it should be, as are the artery that goes out to the right lung. And this is the right pulmonary artery, and then this is the left pulmonary artery, and they're both bigger than it should be. And this patient has had open heart surgery in the past because there's sternal wires. These are pictures from different patients, but the picture on the left shows a catheter going through the right heart out to the pulmonary artery. An injection in the pulmonary artery shows the pulmonary artery to be bigger than it should be. And that's typical for someone with pulmonary hypertension. The main pulmonary artery and the proximal portions of the pulmonary artery to the right lung and the pulmonary artery to the left lung are bigger than they should be. But because of the pulmonary hypertension, as those arteries get further out and as they divide into smaller branches, they become quite small. And that's what the picture on the right shows, that this is a catheter that's through the main pulmonary artery and through the branch pulmonary artery into a smaller branch. And the arteries that dye is going into, the branches are quite small. Because of the pulmonary hypertension and because the artery is small, the blood is having trouble getting out into the distal part of the lung arteries. For some patients, we'll also use a CT scan of the chest or a CT angiogram to look at the lung arteries. And this is a mock-up. This is a still frame of a CT scan of the chest that also shows a large main pulmonary artery and large branch pulmonary arteries. We also use a CT of the chest to look at the lungs themselves, to look at lung disease. I'm not a pulmonologist, so I didn't pull the images of the lungs. This is of a patient without lung disease, so he had normal lungs, but only large arteries. Some patients with pulmonary hypertension can also have liver disease. So typically for a patient at diagnosis, we'll do a CT of the chest to look at the pulmonary arteries. We'll look at the lungs, and we'll also do a CT scan of the liver to look for liver disease. That's typically the test we do for diagnosis. And from that standpoint, then we start to think about how sick the patient is, kind of what category they fit in, whether it's mild, moderate, or severe disease, how functional they are, and basically how sick the child is, if they're in heart failure or not. And from there we sort of think about therapy, and sort of think about what therapies really going to offer the patient. And kind of my goals for therapy are kind of multifold. My ultimate goal is sort of reverse pulmonary hypertension. That's difficult with patients with idiopathic primary pulmonary hypertension. With patients with secondary pulmonary hypertension, if they have lung disease, they have interstitial lung disease, that's sometimes possible, because if the lungs get better, then often if a secondary cause of pulmonary hypertension gets better, then often the pulmonary hypertension will get better. So I would say that if the interstitial lung disease gets better, if there's liver disease and the liver gets better, if there's an inflammatory disease and we can make that better, then pulmonary hypertension will get better. My next goal is to help kids to live longer, is to improve their survival, decrease their mortality. Then it's really to kind of just, if those two, barring those two things, it would be to stabilize their pulmonary hypertension, to keep their pulmonary hypertension from continuing to get worse. Because often if we don't intervene and don't treat pulmonary hypertension will continue to get worse, and their survival will go down. Next would be just to improve symptoms, to kind of help kids feel better, to make them be able to go about their day-to-day activities better, improve their exercise tolerance, and help them be able to go back to work if they're working, get back in school, get back in some of their normal activities. And then treat an underlying disease, treat work with their other subspecialists, treat their lung disease, and kind of get them through the pulmonary hypertension, and hopefully their underlying problems will get better. And then also, I think this is important. I think as a pediatrician, I feel like we treat this more than our adult colleagues do, but we kind of avoid side effects, and not just short-term side effects, but also to avoid long-term side effects, so that we can get kids not just 5 years, but get kids 10, 15, 20 years, and get them into adulthood with minimal short-term and minimal long-term side effects. So I think some of the basic therapies that we do are probably the same as what Dr. Curlin and some of my lung colleagues offer. We do oxygen, because I think oxygen is probably the most potent pulmonary vasodilator that we have. I think it works better than most of the other medicines that I have to offer. And it's got fewer side effects. So I think especially the patients that have lung disease should be on a small amount of oxygen, at least. Often our patients would be on heart failure medicines, which I won't go to specifically. And then patients would need to be on some type of anticoagulant or blood thinner, usually Coumadin or warfarin as a trade name. If we talk about specific pulmonary hypertension therapy, I think there's still a role for calcium channel blockers. A brand name for which is Procardia, Procardia XL, or nifedipine is what we typically use. And then I've got in boxes in red the ones that I'll specifically talk about. One is sildenafil. The trade name is Revatio. A similar medication is tadalafil or Adcirca. Another class is Bosentan, the trade name for which is Tracleer. The longer-acting version is called Ambrisentan or Letairis. All of those are oral medications. When you have to escalate to other medications, there's a group of prostacyclin drugs. The inhaled versions are called iloprost, or brand name is Ventavis. A similar drug to iloprost is treprostinil, with the brand name of which is Tyvaso. Both of those medicines are inhaled. It's not exactly. It's sort of like a metered dose inhaler. It's not exactly a metered dose inhaler, but it's not a nebulizer either. It's a little bit in between the two. They're a little cumbersome to use, and I won't go touch much on these specifically. Iloprost is the one that's approved for use in children. Unfortunately, iloprost has to be given 6 to 9 times a day to really be effective. So it's often difficult for small kids to do. It's even really difficult for adults to do, specifically to do that many times. Treprostinil is more convenient, but it still has to be done 4 times a day, and really should be done 4 times a day, broken apart. We have 2 children that are in school that are using treprostinil, and it's difficult to get those many doses in a school day, so to the point that they have to get a dose in school. And it's not FDA approved under the age of 18, but we've been able to work around it, particularly in teenage patients. The IV versions of those medications are epoprostenol or Flolan, and then the IV version of treprostinil is Remodulin. Remodulin is also available as a subcutaneous medication. So this is a busy slide, but I just want to point out that if we talk about the endothelium pathway, Bosentan works in this pathway. Sildenafil and tadalafil work in the nitric oxide pathway, and the inhaled and IV medications work through the prostacyclin pathway. There probably is some crossover of all those medications, but we don't have a medication that's a glass ceiling medication. We don't have a medication that interacts and affects all the pathways. And we don't have a medication that reverses pulmonary hypertension once it happens. All of our medications really just stabilize pulmonary hypertension and slow the progression of pulmonary hypertension. The only way we can really reverse pulmonary hypertension is with pulmonary hypertension with a secondary cause. Pulmonary hypertension due to lung disease, pulmonary hypertension due to liver disease. And in that case, if the liver disease or lung disease gets better, or if the lung disease goes away. So a baby with chronic lung disease, and as they get older, the lungs heal, and the lung disease goes away, the pulmonary hypertension will go away. That's really the only times we have where the pulmonary hypertension in and of itself will go away. But if we have a patient with interstitial lung disease that continues to progress, with pulmonary hypertension, the pulmonary hypertension in and of itself will also either stabilize at best or over time will continue to progress. Our patients with idiopathic pulmonary hypertension, kind of the best we hope for is stabilization of pulmonary hypertension and to keep it from progressing over time. But even the natural history of that is that at some point it will continue to get worse, and eventually our medicines will fail. At least the medicines we have now. There's always research being done, new medications coming down the pipeline. So there's hope for like 10 or 15, 20 years out that if our medications do fail, there'll be something else in to take its place. But as of now, there's not. I think I'm getting close to being done, but I'll kind of run through the therapies a little bit more specifically. Sildenafil, the benefits of sildenafil, I think are important because that it can improve exercise tolerance and improve symptoms. There are some subset of patients where I think it does improve survival. For kids, this was shown in both the trials called the START-1 and the START-2 study. The START-2 study made some kind of waves last year and was important and made some waves in the media because preliminary data from the START-2 study was presented at a European meeting in the fall. It was picked up by the FDA, and the START-2 study showed an increased mortality in patients with sildenafil. So it showed that some children with sildenafil had an increased chance of dying if they were on sildenafil. And those were children that were on high-dose sildenafil, usually higher dose sildenafil than we would typically use. In some cases, 2 or 3 times the dose of 2 or 3 times the adult dose of sildenafil. And those were children that were only on sildenafil. So they weren't on any of the more potent medications. And so because of that, an FDA black box warning came out about sildenafil, and the black box warning is for children age 1 through the age of 18. So kind of my take-home message for parents is kind of twofold. One, we give parents a copy of a summary of the START study now and a letter summarizing our thoughts on it. And kind of our thought is that families should just be aware of this, and we don't have the full data because the study is not complete, and the full data hasn't been published yet by the study group. But my thought and my partner's thoughts, and from talking around the country, other groups' thoughts is the patients in the study that did poorly on sildenafil, that died on sildenafil, probably should have been on other medications. Probably should not have been on as much sildenafil as they were on, and probably should have been on other medications to begin with. So they were probably sick patients that may have died anyway. They probably shouldn't have been on as much sildenafil as they were on, and they probably should have been on more potent medications to begin with. So the fact that they died on high-dose sildenafil is bad, but they probably would have done poorly anyway, and they may have done poorly even if they were on other high-dose medications. And that's about all we can really say from that because a lot of the information hasn't been published or released yet from the authors. I know some of my partners have talked to some of the authors that were involved with the study. I think sildenafil is important for patients with pulmonary hypertension and lung disease because sildenafil is one of the only pulmonary hypertension medicines that's been proven to help children that have lung disease and that have pulmonary hypertension due to their lung disease. And it's been shown to work only in small studies, in studies of children with 100 to 200 patients. There aren't any large studies of pulmonary hypertension in patients with lung disease. So there haven't been any studies of thousands of kids. And there also aren't any large studies of taking thousands of kids with pulmonary hypertension and putting them on therapy and comparing them to kids without pulmonary hypertension or that aren't on therapy. So everything I talk about is either kids that are on therapy versus kids on therapy A or therapy B, or putting kids on 2 therapies and seeing which therapy is better. So we're talking about sildenafil. Sildenafil is in a class of medicine called a phosphodiesterase inhibitor, which I don't think is important to know. But the brand name of sildenafil we use for pulmonary hypertension medicine is Revatio. And there are some ads on TV for Revatio or Adcirca for pulmonary hypertension. The main way that sildenafil is advertised is Viagra. Tadalafil is advertised as Cialis. They're both used for erectile dysfunction in adults, and it works for erectile dysfunction in a similar mechanism, and basically the same way. But we know for kids and for adults, they also work as pulmonary hypertension through the same method. So for bosentan and the other medicines similar to it work in a different way. The trials in which bosentan was tried is called the BREATHE trials. It's been shown to improve exercise capacity. So it makes kids feel better. It improves their walk time on a 6-minute walk test. I think of bosentan as a weaker pulmonary vasodilator, so a weaker medicine compared to sildenafil and compared to the next medicines that will show. It may improve survival. There's been one of the BREATHE trials showed a slight improvement in pulmonary hypertension based on catheterization and decreased in mortality. The other BREATHE trials did not show that. Important for bosentan is it affects the liver and has significant liver toxicity. Up to 15% of patients on high-dose bosentan have had liver toxicity in trials. It's limited access from the FDA. The FDA requires monthly labs if patients are on sildenafil. On bosentan, whether they're children or whether they're on adults. So we adhere to that and follow follow liver function tests and other blood work on patients on bosentan closely. So I talked a little bit about the inhaled prostacyclins with iloprost. They're somewhat cumbersome to use. Unfortunately, the inhaled agents haven't been shown to really impact mortality that much in children. The only medicine that's really been shown to impact mortality in children is Flolan. Flolan is a prostacyclin medication. It's an IV medication. It requires a continuous IV infusion, and with that, it requires a permanent IV line. It requires a good IV line, so it requires what we call a central line, which is a line usually in either the big vein of the neck or a big vein under the collarbone, as kind of this mock-up is showing. This is a patient that I took. This is a slide I took from one of my mentors. So it's a patient that's obviously in the hospital. That he's probably just gotten his Flolan and a central line. It shows an IV going into the skin, into the chest. He's still in a hospital gown. The pump on his chest is the size of a pump that the Flolan goes into. The pumps for the lines that we send kids home with for Flolan are very small catheters. The pumps that we use for IV infusions at home then are small pumps. There's specialty home pharmacies that work with us for Flolan infusions at home. Flolan has a very short half-life, a half-life of only 1 to 2 minutes. So if a pump malfunctions, or if a line breaks, or if there's a problem with a Flolan infusion at home, that's an emergency. And if there's an interruption of Flolan infusion, patients can become quite ill with only a few minutes. Flolan is also only stable in cold temperatures, so if someone's on Flolan at home, their pump has to be packed around ice. Having said that, Flolan can make a big improvement in kid survival, and to the point that we know we've had kids that have survived 10 to 15 years on Flolan that were quite ill at the time of diagnosis. For the most part, we try to we do still continue to use Flolan, especially in the hospital setting, and we send kids home on Flolan that we think are quite ill and that need IV therapy, and we think that's the best option for them. For older children and for children that we think still need IV therapy, we do try to use Remodulin instead of Flolan. The advantages of Remodulin are it has a longer half-life, but it's still relatively short. It has a half-life of 4 hours. That's still long enough that if there's a breakage in a line, if there's a problem with a pump, then that's easier to troubleshoot, and it's usually time enough for kids to either get to a large ER, not just a small county ER, but usually to more of a children's hospital. So a line can be fixed or a pump can be fixed, or to bring them back to Pittsburgh. It also doesn't have to be kept cold. So the pumps are usually a little bit smaller, and the pump does not have to be packed around ice. Remodulin can also be given as a subcutaneous infusion, similar to an insulin pump. We don't have any patients on a subcutaneous infusion, but if you talk to adult centers, most adults that are on an IV process, on a prostacyclin, will be on Remodulin rather than Flolan, and probably 70% will be on subcutaneous Remodulin. And the subcutaneous Remodulin works quite well. It works as well as IV Remodulin. The data for Remodulin has not shown that it impacts mortality like Flolan, but part of that's two reasons. One, that there haven't been as many studies done with Remodulin compared to Flolan, and the studies that have been done in kids, they haven't been as big of studies. And with the adult data, it seems to work just as well as Flolan. So to remind you, I showed this slide before talking about functional class. We talk about how sick kids are, we talk about how bad their pulmonary hypertension is. I sort of grade pulmonary hypertension like I do everything else. I grade it as mild, moderate, or severe. I try to keep things simple. And we base that sort of off the echocardiograms, off of their cardiac catheterization. But that often won't tell me how well kids are doing. Often how well kids are doing is based on how well they feel, how much symptoms they have, and usually is how their right heart failure is. And with that, I kind of use their functional class, or the World Health Organization score. And that's important when we start to think about what therapy somebody needs. Because when we talk about therapy, I presented, treatment of just treating the underlying disease. We talk about oxygen, which, even though it's kind of cumbersome to wheel around, is simple. It's simpler and has fewer side effects compared to the other medicines I talked about. I talked about oral medicines, talked about inhaled medicines, and then showed IV medicine, which is probably the most side effects of any of all the other medicines I talked about, and probably has the most side effects of anything else that I prescribe as a cardiologist. So now I kind of think then about medicines and about therapy in two ways. I sort of think about risk and whether patients are low risk or high risk. And then I think about whether they have right heart failure. And if they don't have right heart failure, that's low risk. If they have right heart failure, they're high risk. I think about how sick somebody is and how their symptoms are progressing and how fast they've gotten sick. If they have progressed gradually, then they're low risk. If they have had rapid progression of symptoms, if their pulmonary hypertension has seemed to come on quickly, then they're high risk. If they're World Health Organization class 1 or 2, they're low risk. If they're class 4, they're high risk. If they're a class 3, they're probably somewhere in between. If their 6-minute walk test is good, if they've walked a long way for their age, they're low risk. If they've walked, it's not good. If they walked a short distance for their age with a good effort, it's a high risk. If their echo is good, they're low risk. If their echo is bad, they're high risk. And meaning bad, not just pulmonary hypertension numbers, but I'm talking about function, the squeeze of the right heart, and the squeeze of the left heart, and that's bad. If their numbers at cath are good, then they're less low risk. If their cath numbers are bad, if their pressure on the right side of the heart is high, then that's high risk. And from there, I sort of think about treatment. The first thing we start with is general treatment. We start with anticoagulation with Coumadin. I think about heart failure medicines with diuretics, water medicines, oxygen. I think there still is a role for calcium channel blockers as a first-line medicine. My group tends not to use calcium channel blockers as much. We still have some older patients on calcium channel blockers. Some of the other pulmonary hypertension groups use calcium channel blockers as first line on everyone. The patients I've seen that come from Columbia and New York, a lot of patients are on calcium channel blockers. The benefits of calcium channel blockers tends to wane over time. Not everyone responds, and the patients that do respond, usually within 5 years out of therapy, they're usually not responding anymore. From there, I usually then start to think about risk. On the slide before, I started thinking about whether patients are low risk and high risk. And it's not just based on their numbers. It's sort of based on the patient as a whole. It's based on what's wrong with them. It's based on whether they have lung disease or not that we can treat. It's based on how their symptoms are. A lot of it's just based on how sick a kid looks. If they're low risk, then they usually start with oral medicines. The sildenafil that I talked about, bosentan that I talked about. Sometimes we use a combination of drugs. It may escalate to an inhaled medicine. If they're high risk, then we'll go directly to an IV medicine. either Flolan or Remodulin. If they're a little bit in between low risk and high risk, then we think about the inhaled medicine, the iloprost or treprostinil. Patients can also, there's also a way patients can change. Patients can move over. So patients can start with a calcium channel blocker, move to a low risk. Patients can be low risk for a couple of years and then move over to the high risk. And at the bottom right-hand corner, it's kind of the big bad in the room. We talk about lung transplant. That's when patients fail therapy. If they show up extremely ill and they're in our ICU, or if over time, if they've been on high-risk therapy and they've been on IV therapy and the IV medicine starts not to work, their pulmonary hypertension continues to progress, then we talk to families about transplantation. I think transplantation in and of itself is probably a separate talk. And when I talk to families about just the basics of transplant, that's an hour and a half to 2 hour talk. But it's the final answer for pulmonary hypertension. It's the end answer for pulmonary hypertension. When medical therapy has failed, we either offer evaluation for double lung transplant or for heart lung transplant. And I can answer some questions about this if anybody has questions. So I kind of went through objectives of kind of defining what was pulmonary hypertension, the causes of pulmonary hypertension, and kind of looking at what the symptoms were depending on age, depending on what was the underlying cause of pulmonary hypertension. I try to kind of go through how, as a cardiologist, I make a diagnosis, and then going through therapies. And then I think that was it.
I have a real quick question for you. So with knee-high and several of the chronic lung diseases where it's kind of vague about how often we should be having cardiac evaluations for long term, and we get periodic echoes, but I didn't know if we should be concerned about missing pulmonary hypertension or if there was a standard for how often these kids should be evaluated for cardiac changes. Right,
and that's a good question. I decided not to put that in a slide, but there's actually in the consensus statements, both the American College of Cardiology and the European consensus statements, there's some recommendations from both groups about how often patients should have echocardiograms. Once they have diagnosis of pulmonary hypertension, you should have echocardiograms. You should have a 6-minute walk test. You should have plus or minus a cardiac catheterization. And to be honest, I know my group doesn't follow these recommendations, and I would suspect most groups do not. For the most part, we do all those tests more often. The recommendations are to do an echocardiogram every 6 months, do a 6-minute walk test every 6 months to once a year, and we usually see our kids probably every 2 to 3 months. And every time we see a kid, we do an echocardiogram, we do an EKG. If a patient's seen in the ER, whether they're seen in the ER for something as a cardiologist I know is not due to pulmonary hypertension, the ER wants an echocardiogram, so they get one. So anytime they come in to the hospital and they're sick, they get an echocardiogram. So they get studies done in between. So I would say that based on our national recommendations, we do everything more often. I think for a patient with lung disease that does not have pulmonary hypertension, I don't know of any specific recommendations about how often they should see a cardiologist. I know there are some recommendations about how often they should have how often they should be screened. And I would imagine in the new guidelines that are coming out for lung disease that Dr. Curlin's doing, I would imagine that would probably be addressed in those guidelines, and that may be helpful. Some of this can be institution dependent. So at Children's of Pittsburgh, the lung group, if they want a patient to have an echocardiogram, if they think a patient should have an echocardiogram as a screening tool, then those patients will just order an echocardiogram. And then if Dr. Curlin and Dr. Spar have a question, we'll talk about them at our group heart-lung conference. So they'll ask me or one of my partners about it. And then if they want to get referred, they'll get referred. And we sort of do the same way. If I have a question, I'll talk to one of the lung doctors about it, and then I'll do a refer. where I was a fellow, the only way to get an echocardiogram for that would be refer him to cardiology, have him see as a consult, and then get an echocardiogram.
Okay, are there any other questions? Yeah.
Just wondering how reliable an echo is on a toddler that's moving, crying, stressed. How accurate are your reads on the pressures and stuff? Because our daughter has had several, and they say what they can see is normal, but they always come back as inconclusive because she's terrified during them.
Right.
So she is going for a sedated echo next month because
Right.
The cardiologist wants to say for certain that her heart is fine. So just wondering, you know, after this sedated echo, I don't plan to hopefully have any more that are sedated. Hopefully that we can get through where she can go for them every 6
Right.
months or a year and be awake during them. But if she is screaming, crying, moving, terrified, are you really going to get an accurate read?
Right. Yeah. So the toddler is the is probably the worst age for having studies done, just because of stranger anxiety and particularly everything else. So I would say with an echocardiogram, even if we don't get a direct measurement, and to get a direct measurement, we have to have leakage of the valves, particularly the valves on the right side of the heart. Even if there's not leakage, even if we don't get everything lined up to get an estimate of the pressure on the right side of the heart, I can usually say that there's direct or indirect evidence of pulmonary hypertension. If there's severe pulmonary hypertension, we can tell just from how the chambers look, without even being able to measure with the leakage of the valves. And if there's severe pulmonary hypertension, there's almost always significant leakage of the valves. Having said that, I have been fooled at times with thinking by echocardiogram there was not significant pulmonary hypertension. And after getting a better echocardiogram, whether sedated echocardiogram or getting a cardiac catheterization, pressure was higher than what I thought. So I think, you know, if they're not able to get a good study, probably the simplest step would be to do a sedated echocardiogram. And we do the same thing in our lab. We'll try a non-sedated echocardiogram and then go to sedated echocardiogram.
And would the echo be helpful to rule out any other or all other structural problems with the heart? My daughter, she has a rare genetic diagnosis that comes with a huge list of potential heart defects, and so this is why they're wanting the sedated echo, to be 100% sure that she doesn't have pulmonary hypertension, but also to look at and rule out anything else structurally wrong with her heart?
Yes.
Okay, so they'll be able to get everything that they need from her in that one echo. They already did like the EKG and stuff on her.
Yes, I would say so. The other way to look, because one thing I didn't talk about, but structural heart disease that can cause pulmonary hypertension would be a hole in the heart. So a large VSD, which is a hole between the bottom chambers of the heart, or a problem with the left side of the heart, a problem that would cause the pressure in the left side of the heart to back up into the lungs. So whether it's a problem with the valve in the left side of the heart, or a problem with the pulmonary veins that return blood from the lungs back to the left side of the heart. The other way to look at the structure of the heart is a cardiac MRI. A problem with the cardiac MRI, even not just for a toddler, but for a small child, that requires anesthesia and complete anesthesia with a breathing tube. Okay. A cardiac MRI takes an hour and a half to 2 hours. So I think, you know, if she's having an MRI of the spine, to also do an MRI of the heart, that would probably be too long. I would say not to do those together, because I think the anesthesia time for that then would be too long. I would recommend doing, they need to do that, I would recommend doing, at least our approach would be doing them separately. And I would start just with a sedated echocardiogram.
What if during the results of a lung biopsy, it came back with the pulmonary arteries are already thickening? So is that an indication of any type of pulmonary hypertension, you know, the beginnings of it, or is that just normal with a lung disease?
So I think indirectly you wouldn't be able to say that that's concerning for pulmonary hypertension, but it wouldn't be definitive for pulmonary hypertension because it wouldn't tell you what the pressures are in the lungs themselves. And that may be that, and that could be that the one artery is that was in the biopsy was thick, but that may not be all of the lung arteries are thick. But that would be concerning that all of the lung arteries are thick. Concerning for pulmonary hypertension, in which case that should be evaluated as well.
What about increased tricuspid regurgitation, but everything else is fine on the echo, but that seems to be increasing every year with the echo? Is that a concern?
Yeah. So there are different things that can cause just tricuspid valve regurgitation. Either a problem with the ventricle itself, or a problem, or pulmonary hypertension can cause tricuspid valve regurgitation, or a problem with the function or the squeeze of the ventricle, or a problem with the tricuspid valve. But some patients just have a lot of tricuspid valve regurgitation. In general, we don't worry about leakage of valves on the right side of the heart as much as we do on the left side of the heart.
Any other questions? Oh, Joe.
My grandson has lung disease, of course, and one of the things that presented at the time of that the diagnosis started showing up was he became like pigeon chest, or he's deformity of the chest near the sternum, and that's beginning to rotate. And I was wondering if that had implications for either the heart or hypertension. Nothing's really showing up in any of the testing, but they're concerned about it. They just mentioned a concern about the function of the heart with this rotation of the chest deformity.
Right, that can. I haven't seen that particularly with pulmonary hypertension, but we think about where the heart is in relation to the breastbone and the body. We think about the heart as being on the left side of the chest. The heart's really more kind of in the middle of the chest, and the point that the pulmonary artery, the artery out to the lungs, is almost right under the breastbone. So if the breastbone's concave, or if it's pushed in, if you've got a pigeon chest, then often that will push on the pulmonary artery, or it may push on part of the chest if it goes in enough. There's not usually a problem with the heart, but there can be some compression, and that we're often asked to do echocardiograms on patients for that reason.
Any other questions? Okay, last one. Did you hear that?
So it's not exactly understood well, but there are some patients that have, I'm probably talking too much, there are some patients that have portovenal shunts, so that have shunts from the vein that goes back to the liver, so that blood bypasses somehow in the liver. Or if you have occlusion of the vein that goes from the spleen back to the liver, those patients develop pulmonary hypertension. It's described in the literature. I have a couple of patients with it, and I really don't understand it well. And I ask our liver surgeons about it, and they also don't really understand it well. But the treatment for them is not, we treat the lung disease and we treat their pulmonary hypertension, but the ultimate treatment is to replace their liver with a liver transplant. And often with liver transplant, their pulmonary hypertension gets better, and in some cases can go away. So we have so that's one thing we look for, because if we miss the liver disease and the spleen and the shunts, then they're diagnosed too late, then they may not be a candidate for liver transplant. Their pulmonary hypertension, they're only a candidate for liver transplant if their pulmonary hypertension is controlled and if it's mild. If they develop severe pulmonary hypertension, then they're no longer a candidate for liver transplant, and we may miss the window when we could successfully treat them.
Thank you. Thank you, Dr. West.